Great. So let's discuss Keynote 689. Dr. Rosenberg, prior to the summer, what was the current standard of care for patients who present with a head and neck cancer that needs primary surgery?
Yeah, so for these patients prior to the summer, this is patients that have number one, local regionally advanced disease, which is defined as stage 3 or stage 4 disease, and um, and have resectable disease, meaning that the first and primary treatment would be surgery. And so these patients prior to the summer, the standard of care was to go upfront to surgery. So, for example, a patient with a tongue cancer that fits this criteria would go directly to surgery to remove the tumor from the tongue along with a neck dissection to remove the lymph nodes in the neck. And that would be followed by either radiation or radiation with chemotherapy. And to answer that second question that you had about who's considered high risk after surgery, this is actually based on the pathology findings following surgery. And some of the key pathologic findings that would make someone high risk to warrant chemotherapy with radiation versus radiation alone are pathologic findings such as positive margin, meaning that the cancer goes all the way up to the margin of where the surgeon does his resection, or having something called extranodal or extracapsular extension which means that the cancer cells under the microscope are going beyond the capsule of the lymph nodes, sort of the walls that we see around the lymph node. There's a number of other what we consider intermediate risk features, so not quite as high risk, but more intermediate risk, which are things like perineural invasion. Do the cancer cells get into any of the nerves? Lymphovascular invasion. Do any of the cancer cells microscopically get into any of the blood vessels or any of the lymph vessels? Are there many lymph nodes involved? Those are some of the other, intermediate risk criteria, but those are the main high risk pathologic criteria prior to the summer.
Thanks, Ari, for providing that information. And Dr. Kazmar, can you summarize the key findings in Keynote 689?
Yeah, so I think first I would just say briefly the design of the study, looking at standard of care, as Dr. Rosenberg described, surgery followed by risk-adapted radiation or chemotherapy and radiation. The study randomized half of patients to get that, and then the other half of patients got 2 doses of neoadjuvant pembrolizumab, followed by surgery within 6 weeks of the receipt of the first dose, followed by radiation or chemoradiation as dictated by the pathologic features. And during that chemoradiation and subsequently to complete a year, pembrolizumab was given. So that's what was done on the study. The endpoint that was presented of the primary was event-free survival, which means that the patients were alive without a cancer recurrence, whether it be distant or metastatic. And the finding was that the patients that were treated with the immune therapy perioperatively had, at 3 years, significantly improved event-free survival, roughly just south of 60% versus right around 45%. So basically an absolute improvement, just shy of 15%, which is pretty impressive in this high risk, stage 3, stage 4 patient population.
Yeah, John, and can you comment on the overall survival data?
So overall survival data is immature at this time. I think is trending towards that there may be a benefit. So we'll see that updated, but right now that the top line finding is EFS, event-free survival.